We want to introduce Dr. Brittany Weber today. Dr. Brittany Weber is an instructor of medicine at Harvard University Medical School and associate physician in preventative cardiology and cardiovascular imaging at Brigham and Women's Hospital, where she directs the Cardio-Rheumatology Clinic. Welcome, Dr. Weber.
Thank you very much for having me.
Of course. Your spring session was on the links between common inflammatory conditions and cardiovascular risk, more specifically, the less obvious signs. Can you give us some pearls from your session and what you hope attendees can put into their practice?
Of course. Well, first, I'd like to thank you for the opportunity for me to talk about something that's really, really my passion. And I think some of the pearls of what I was hoping to kind of give an overview of my session today was that the cardiovascular manifestations within these disease conditions is vast, but there's this extremely important link of the underlying role of the systemic inflammation, and importantly in promoting cardiovascular risk. And so some of the key take-home pearls that I was discussing today is that our standard kind of way we approach a general patient without these inflammatory disorders, if they don't adequately help us estimate risk. And so this is where physician education and awareness and patient education awareness and I talked a lot about in my talk today about how we can maybe utilize some of these other biomarkers and also cardiovascular imaging and understanding risk in these patients, as well as how the cardiologist can work with the rheumatologist, dermatologists, other disease specialty, and care models to be treating these patients.
And how important is it for clinicians that see patients with elevated cardiovascular and cardiometabolic risks, such as PCPs, endocrinologists, cardiologists, to be aware of a history of common inflammatory conditions and take them into account for risk assessment?
That's an excellent question, and I think it's very, very important. You know, every week I meet a patient that comes to me and they were like, I had no idea I was at increased cardiovascular risk. And so that really should have increased awareness, and the primary care physician should recognize that a patient who comes to their clinic with rheumatoid arthritis, that they are at that increased risk, and that should prompt referrals or at least prompt the discussion with the patient, sometimes checking additional biomarkers. But I think also for the specialists, the rheumatologists, I would say that at least in our hospital, I think there's a very wide recognition of the increased cardiovascular risk, but across the United States, I think it's really important for those providers who are caring for those patients that they understand that increased risk and at least talk about it with their patients and or refer to a cardio-rheumatology specialty as well.
And how can cardiometabolic clinicians and rheumatologists, dermatologists work together to address the simultaneous concerns of patients with systemic inflammatory conditions, but also with a high cardiovascular burden?
Yeah, what excellent question. And this is what I get really excited about, because this is really my passion here, the idea of cardio-rheumatology, and really this is collaborative care models. And so I think that, there's a few of these clinics popping up across the U.S. We're working hard on our clinic at the Brigham and Women's Hospital, but I think we work together in collaborative care models. My dream would be that these clinics could be even situated in the same kind of same location. Logistics, that would be, that's something to work towards for the future. But imagine a day where a patient can come see their rheumatologist, see their cardiologist, and then the two can discuss. I don't think it has to be that way. I think they could still be on separate days, but the communication between the cardiologist and rheumatologist should be interactive, right? There should be discussions. For instance, there's therapies that have increased cardiovascular risk associations. And so perhaps it's the cardiologist that's seeing the patient, and then it's discussions with the rheumatologist as how can we pick the best anti-inflammatory agent to both reduce their cardiovascular risk, and what are the therapies we can add on in addition to lower the risk independent of their anti-inflammatories.
So I'm going to close out this session. I'll just say, any last pearls or clinical conclusions that you'd like to share with the audience today? One of my pearls that I love is that I think it's always an important pearl to remember, just to really listen to our patients. I love meeting these patients every week. They have often years of being underdiagnosed, and you can learn a lot just by listening to them and listening to their story. And then another pearl, as I say, is learning from each other. I learn every day from the rheumatologists and the dermatologists I work with. And just like I teach them a lot about cardiovascular risk and treatments, and we should use statins, they teach me a lot about their biologics. And so I think we should always remember that between the two.